Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and our wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from France, Professor Thibault Passeri. Dr. Passeri is a consultant neurosurgeon at the Hospital Lariboisière in Paris, France. He is currently pursuing a skull-based fellowship at the UPMC, USA. His clinical interests are focused on skull-based surgery, especially endoscopic skull-based surgery. He has published several articles on various skull-based tumors, especially Chordomas. He has been a faculty in the microscopic and endoscopic skull-based workshops at IRCAD, France. He is a member of the scientific committee of the French Association of Chordomas Surgery, and is also a member of the ACNS. We are extremely honored to have him today at our webinars, and today he will be talking about new technical advances in the management of skull-based chordomas. The speaker for the second session of today's webinar is our honorable guest from China, Professor Xin Shen. Professor Shen is the Vice Chair and the Chief of Department of Neurosurgery at the Tianjin Medical University General Hospital, and is currently a professor and doctoral supervisor at Tianjin Medical University. He has been trained in several world-renowned centers like MGH, Harvard, Brigham and Women's Hospital, University of Pittsburgh Medical Center, and UCSF. His neurosurgical expertise includes headache and facial pain, Glossopharyngeal neuralgia, trigeminal pain, movement disorders and disorders of consciousness, epilepsy, and restoration of neurological functions. He has been honored with several awards for his outstanding work in neurosurgery, and we are extremely honored and grateful to him for accepting our invitation to be speaker at webinars. And today he will be talking about microsurgical anatomy and surgery for glossopharyngeal neuralgia. Chair for the first session of today is our honorable faculty from Japan, Prof. Takio Goto. Prof. Goto is the chairman and professor of neurosurgery at the Osaka Metropolitan University Graduate School of Medicine, Osaka, Japan. He is a world-renowned endoscopic skull-based surgeon, and he is an invited faculty to several workshops and conferences around the world. He is an integral part of the ACNS education, and he was also the chairman of the Neuroendoscopy Committee of the WFNS. He has published extensively about endoscopic skull-based surgery, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our distinguished faculty from Singapore, Professor Vincent Eng. Prof. Vincent is a consultant neurosurgeon at the Mount Elizabeth Hospital, Singapore. He was the previous head of Department of Neurosurgery at the National Neuroscience Institute, Singapore, and he was also the co-director of the Endovascular Center and director of Joint Neurovascular Services at the NNU, Singapore. He is the current Vice President in Clinical Neuroscience Society, immediate past chairman of the chapter of Neurosurgeons, Academy of Medicine, Singapore, and is also a member of the CNS and AANS, and is an expert in endoscopic skull-based surgery and also the host of recently concluded meeting of the IFNE. We are extremely honored to have him to chair the second session of Professor Xin Shen. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Prof. Takio Goto.
I feel very honored to chair this session. Today, first speaker is Professor Passeri from France. I know that he worked with Sebastian, so we know him well. So today his topic is new technical advance for chordoma surgery. Chordoma is one of the very difficult skull-based tumor. So we want to know how to manage the chordoma treatment. I think the Sebastian and Thibault group is one of the big center for treatment of the skull-based chordoma. So I'm looking forward to listening to his lecture. So please start the first lecture, Professor Passeri.
Thank you, Professor Goto. Thank you to moderate this session. Thank you for the ACNS to invite me for this beautiful webinar. So I'm Thibault Passeri. I'm a neurosurgeon in Lariboisière Hospital in Paris. And I would like to talk about new advance in the management of skull-based chordoma. So I work in Lariboisière Hospital, and my department, the Lariboisière Hospital, has progressively developed huge experience in chordoma surgery with my mentor, the Professor Sebastian Folisch, and in the past, the Professor Bernard Georges, who has developed this complex surgery in Paris, France, to treat some skull-based case and skull-based chordoma, but also some cervical and sacrococcygeal chordomas. We have now operated more than 400 tumors in these locations. So chordoma is a challenging tumor because it's a rare tumor with an incidence about 1 for 1 million people. Their origins, the chordomas come from the notochordal origin. And what is a notochord? The notochord is a rod-shaped structure playing crucial role in the development of organ, especially the spine during the embryological period. And the notochord spread from the future skull base to the future sacrum, explaining the midline location of the chordomas and also their main location into the clivus and cranial junction, as well as the sacrum. For the pathology, the new WHO classification published in 2020 distinguished 3 types of chordoma. The conventional chordoma, grouping the X-classic and chondroid chordoma, which represents the most frequent one. The dedifferentiated chordoma, the less frequent one, less than 5% of all chordomas, in its particularly aggressive form with sarcoma features. And a new one, the poorly differentiated chordoma, characterized by the loss of INI1 protein or the corresponding SMARCB1 mutation affecting the Swiss-Nif complexes. This type is more frequent in the young adult and in the pediatric cases. That you have to keep in mind that the only immunohistochemical marker proving the diagnosis of chordoma is the positivity for the brachyury protein, which is important intranuclear factor in the chordoma genesis. The gold standard treatment for skull-based chordoma now is a surgical resection, and achieving gross total resection is the most important prognostic factor for this complex tumor, and is a factor not debated in the literature. The adjunction of the proton beam therapy has also considerably increased the rate of progression-free survival and overall survival for patients with chordomas. However, the recurrence rate are high, and in the next year, the half of the patient will present a tumor recurrence. We published our series in GNS 3 years ago. In our experience over 29 years for 210 chordoma, and we confirm that gross total resection and the adjunction on proton beam therapy confers a better outcome for the patient in terms of progression survival and in terms also in overall survival compared to other extent of resection and proton beam therapy, but also gross total resection plus proton beam therapy offer better result than other radiation therapy modalities. So our series, usual experience confirms that gross total resection is very important, and the adjunction of proton beam therapy also increase the overall survival and progression survival for patients with chordomas. However, when you look at the global survival curve of our series, you can see that there is 2 groups. In first group, in which patients present early recurrence in the next 5 years, and another group in which patients presented no recurrence or recurrence very late. So you can consider now there is no one type of chordoma, conventional chordoma, but different behavior for this tumor with high grade and low grade chordomas. Moreover, achieving gross total resection with aggressive surgery leads to severe morbidity for the patient. And here you can see in this table the rate of complication and mortality in all our series. We can see that you have a lot of CSF leakage, about 12% for the whole series, rate of meningitis, some issues about the reconstruction technique, now flap necrosis, and also a worsening of cranial nerve palsy or new cranial nerve palsy. And even we can also observe that there is some mortality due to this surgery, and we had 7 deaths in our series, deaths due to bacterial meningitis, hemorrhage, delay, ACA rupture for patients previously radiated, brainstem edema, and also medical complication as postoperative pulmonary embolism. Radiation therapy is the perfect and adapted tools for chordoma, because chordoma is a radio-resistant tumor, and proton beam therapy can deliver a high radiation dose for this radio-resistant tumor, sparing the organ at risk. But also radiation therapy, due to the high radiation doses, can lead to severe toxicities and morbidity for the patient, as anti-hypophysis insufficiency, cranial nerve neuropathy, and radionecrosis in temporal lobe, and eventually in the brainstem. And you can see in this MRI. And this radionecrosis could be symptomatic and severely impact the patient quality of life for these patients. So in the new management of chordoma, considering that chordoma cannot be cured with surgery and proton beam therapy, and considering that achieving gross total resection could lead to morbidity, and there are a lot different behavior of chordoma, the new management of chordoma should balance tumor control and patient quality of life, incorporating prognostic factor in order to adapt the aggressiveness of our treatment to the aggressiveness of the tumor. In the aim of this management is to preserve the patient quality of life. So the future for the management strategy for skull-based chordoma is to predict the tumor evolution and the aggressiveness of the chordoma using different prognostic factors in order to classify chordoma between low-risk group and high-risk groups, and to adapt the management strategy according to this classification. We can use different prognostic marker in the peri-operative period. During the preoperative period, you can use some imaging or eventually blood tissue sample using ctDNA in order to adapt the aggressiveness of our surgery to the aggressiveness of the tumor, even if the achieving gross total resection is the goal for this surgery. But also you can use histological or biomolecular marker in the postoperative period to adapt the follow-up, wait and see, or adjuvant proton beam therapy for the most aggressive ones. So for the preoperative period marker, you use in routine this preoperative tumor growth rate. You published this paper 4 years ago. This preoperative tumor growth rate is calculated between 2 MRI at 3 or 3 months, and allows to evaluate in the preoperative period the tumor growth rate of this tumor. And a high tumor growth rate is correlated with a bad outcome. And with this biomarker, you can have an idea of the aggressiveness of this tumor in the preoperative period to adapt the surgery and the morbidity of the surgery to achieve a gross total resection. Also, this preoperative follow-up could confirm some lesions stable along the time. These lesions are the benign appearing notochordal lesion or very low-grade chordomas, and a strategy consisting to watch, wait, and rescan approach could confirm the stability of the lesion, and this lesion should be not operated, because for chordoma the aim is to gain time and to do the surgery and proton beam therapy as far as possible. Also, in the future, you could use the ctDNA in plasma blood tissue, and is a beautiful paper from Gelarezadeh, published now 4 years ago. She described two groups with different prognosis using the analysis of the DNA methylation in tumor samples, but also in plasma samples. So with just a plasma tissue blood samples, analysis of the ctDNA could distinguish two types of chordoma, and in the preoperative period, that can adapt the surgery and the morbidity of our surgery to the aggressiveness of the tumor. For the postoperative period, we have several markers we can use, and you use in routine in my department, the Ki-67 labeling index, the immunohistochemical marker, on several papers, and we confirm it by different studies in Lariboisière. So your eye correlated with a bad outcome and a less progression-free survival and overall survival. So for this patient with a high Ki-67 labeling index, should be referred quickly to the radiation oncologist to do a proton beam therapy. Also, in the postoperative period, in the new area of biomarker, using different technique analyze the whole exome or the whole exome, you can find different genomic biomarker. And in my department, we studied this biomarker, and we observed that patient with a tumor with mutation affecting the gene, the PI3CA gene, or homozygous deletion of the CDKN2A or CDKN2B gene, correlated with a low progression survival, as you can observe in these two survival curves. GY Bei from China also published different biomarkers, and it confirms that patient with homozygous deletion of CDKN2A or CDKN2B or mutation affecting the Swiss-Nif complexes as PBRM1 or SMARCB1 correlated with a low progression-free survival. So using this new biomarker, you can also classify chordoma into two prognosis groups in order to adapt the management strategies. You can also use the DNA methylation. It was a paper from Gelarezadeh, and there are also several papers in literature showing that using DNA methylation in tumor sample could classify this tumor into two groups. This paper was important. It was published by Dr. Zenonos from UPNC, and it was the first paper proposing a molecular prognostication panel, and using this molecular prognostication panel, adapt the management strategies of this tumor, and they classify chordomas into three groups. The first group, group A, with the best prognosis. So they classify the different group according to loss of two loci in FISH technique, the 1p36 and 9p21. And the 9p21 is a locus for the CDKN2A and CDKN2B gene. So for the group A with the best prognosis, in terms of gross total resection, they propose only to watch and rescan the patient. On the contrary, for the group C with the worst prognosis, in case of gross total resection, they propose to refer quickly the patient to the radiation oncologist. And in case of incomplete resection, they propose to strongly consider a further surgery to achieve a complete resection, because you know for this patient with a bad outcome, achieving gross total resection is very important, even of the cost of some morbidity. And in case of incomplete resection is not possible, patient should receive quick proton beam therapy, and also an early consideration for experimental trial for a new medical treatment. So the future for chordoma surgery and the management of the chordoma surgery is to classify chordomas between two groups, low risk, at risk, or high risk of tumor recurrence, and a shift toward a more personalized treatment using an histomolecular prognostic classification of chordoma. And the aim of this management strategy and the future management is to preserve the patient quality of life and to offer for the patient the best treatment strategy to balance tumor control and patient quality of life. So after talking about biomarker and new evolution of the management strategy of chordoma, I would like to talk about the evolution of the chordoma surgery. Chordoma is a challenging tumor because it's deep-seated, and you have different approach to resect this tumor. We have the anterior approach through the nose, the endoscopic nasal approach, but also you have different transcranial approach with different corridor, anterior, lateral, and posterior to resect these complex tumors. In our experience, we also noted the evolution of this technique and our philosophy. We distinguished three periods according to the use of different open or endoscopic nasal approach. For the first period between 1991 and 2006, we operate the skull-base chordoma located in the three parts of the clivus, lower clivus, middle clivus, and upper clivus, in majority of this case, with a transcranial approach. With the advancement of the endoscopic nasal surgery, you use endoscopic nasal approach for the three locations in the second period between 2007 and 2015. And for the last period, we shift toward a more multimodal approach to resect this tumor. Especially, we shift toward more transcranial approach for lower clivus and craniovertebral junction due to issues of the endoscopic and nasal approach. Endoscopic nasal approach is perfectly adapted for clivus tumor and tumor located in the craniovertebral junction above C2 because chordomas are midline bony tumors, are in the majority of cases soft. You can suck it, and so it is adapted for the endoscopic nasal approach. Are extradural origin, even if there is intradural invasion in the majority of cases, and also they displace the neurovascular structure posteriorly, laterally, and superiorly. So reaching this tumor through the nose allows not to cross this neurovascular structure compared to the classic transcranial or lateral transcranial approach. The main issues are the rate of CSF leak, which remains important, and also the nasal morbidity. When we compare the endoscopic nasal approach and open approach, we have showed that the rate of gross total resection was higher in endoscopic nasal approach compared to an open approach in our series, and also endoscopic nasal approach offer better neurological outcome due to open approach, due to this reason that you don't need to cross this neurovascular structure before reaching the tumor through the nose. However, our rate of CSF leak remains high. It's about 14.8% for the whole series and less than 10% for the primary operated patient. But over the time, we observe a better evolution of best evolution of our rate of CSF leak, with now for the last period between 2016 and 2020 a rate about 11.3%. So during this endoscopic nasal approach goal period between 2007 and 2015, we operate this tumor located in the upper clivus, mid clivus, and lower clivus with this endoscopic nasal surgery, and we use in the past the classic 4 hands technique, 2 nostril technique. with the collaboration between ENT and neurosurgeon, with the ENT holding the endoscope and the neurosurgeon using his two hands to resect the tumor. Also, you use the vascular pedicular nodoseptal flap to cover our skull base defect, and this vascular pedicular nodoseptal flap is important tools and for the evolution of the endoscopic surgery, because it permits to cover big skull defect and to reduce the rate of CSF leak and infectious complications. That you have to keep in mind that if you want to go laterally into the Meckel's cave, infratemporal fossa, petrous apex, you have to create space for this technique with a 4 hands technique and a 2 nostrils technique. So to create space, we have to resect endonasal structure in order to reduce the conflict of between instrument and to have a good corridor to work with the 2 hands and with the 4 hands technique. So in the past, you also resect endonasal structure to create this working space in order to reduce the conflict between instruments. So you use a classic transpterygoid approach, resect all the middle turbinate. You also open the maxillary serous in order to have a lateral access, lateral to the ICA, in order to resect lateral, more lateral complex chordomas. And it was an example of this technique. It is here in a big chordoma, center into the clivus with huge intradural invasion. Also lateral extension into here, we can see on the right petrous apex behind the petrous ICA. And for this chordoma, you use classically the nodoseptal flap technique described in the past to cover this defect. And for the tumor resection, you use this classic 4 hands technique, and the neurosurgeon could, with 2 instruments, remove the tumor from the critical neurovascular structure. Has he resect a tumor with a microscopic technique, and it's a beautiful view of the end of the surgery, showing the brainstem, the different artery, and the different cranial nerve. The problem is that when you resect endonasal structure to create working space, that leads for the patient to severe morbidity, endoscopic endonasal morbidity, and a lot of discomfort for the patient, has nasal discharge, crusting, hyposmia, rhinosinusitis, pain, velopharyngeal insufficiency. If you remove the nasopharyngeal muscle, trismus, otitis media, or an hearing loss, if you remove the eustachian tube to access to the jugular foramen. So for the patient, they have to wash their nose a long time after the surgery. And also you have to keep in mind that these patients, the majority of these patients, will receive proton beam therapy. And also proton beam therapy can lead to morbidity for the endonasal structure due to the effect of the high radiation dose. Moreover, the use of nodoseptal flap also lead to severe morbidity for the patient. And this article shows that the nodoseptal flap was a significant factor for the sinonasal quality of life deterioration after skull base surgery. So in my department with the Professor Folish, we have progressively developed new tools to reduce the endoscopic endosal morbidity while inserting the tumor resection rate. So we have 2 possibilities. You can use multimodal approach, and particularly for craniovertebral junction, in order to reduce the endoscopic morbidity and also reduce the rate of CSF leak. But also you develop in the last years, a new technique, a mini-invasive endoscopic technique, less aggressive approach, taking the advantage of the nasal cavities as a gateway to the tumor access without resection of the nasal structure. And also, we don't use now the nodoseptal flap technique. So here in the past we can use this extended endoscopic nasal approach, resection of a lot of another structure to create working space, to now a more targeted conservative approach, using the nose that a veritable gateway to access to the tumor, and you navigate into the nose without resecting another structure to access to this tumor. This new technique, min-invasive technique, necessitates some adapted instruments, angle scopes, malleable instruments, rotative instruments, and also using this chopsticks technique published by our team several years ago. What is a chopsticks technique? Chopsticks technique is perfectly adapted for small corridors, so perfectly adapted for this min-invasive technique. The chopstick technique, what is it? So the surgeon use in the non-dominant end between all the endoscope between the thumb and the index, and the other tip of the fingers can also hold a suction. It's a rotative suction that permits to rotate and suck the tumor behind black corner. And in the non-dominant end, it can hold another instrument. So we can use 3 instruments into the nose to resect this tumor. That is most important, that is perfectly adapted for the small corridor, because the endoscope and the suction are also held by the another structure. So the smaller is the corridor, the easier it is for this technique. This technique allows to preserve another anatomy and to reduce the impact of our surgery to the another structures. So it's a new technique for clival tumor. So you use this one nostril chopsticks technique. The first step is to lateralize the middle turinate and inferior turinate. And the next step is to incise the mucosa at the junction between the nasal septum and the rostrum. You can expose the contralateral nasal mucosa with keeping it attacked, and we open the sphenoid sinus, and we drill all the rostrum and all the floor of the sphenoid sinus in order to create this working space. You use also angle endoscope. You can also go laterally using this angle endoscope, angle instrument, in order to identify the Vidian canal, foramen lacerum, identify the ICA. And with angle suction, angle instrument, you can resect a tumor behind black corner, as here behind the carotid artery, thanks to this angle instrument and angle endoscope. This technique necessitates a specific instrumentation. It is mandatory for this technique. So you use this drill without shaft and with automatic irrigation system, but also you use the classic the instrumentation, curve instrumentation on angle endoscope, 30 degree, 45 degree, and 70 degree, because you have to keep intact the another structure for the closure. And for the closure, now we don't use any nasoseptal flap for primary patient without a previous surgery or previous radiation therapy. You use this technique that consisting to close the mucosa of the rostrum open at the beginning of the surgery, as you close the skin for a transcranial approach. The first step for this technique is to cranialize the sphenoid sinus. And in order to remove all the mucosa, it could be tough, because sometimes if you have a lateral recess, it could be challenging. But using 70-degree endoscope and angle instrument, you can remove all the mucosa in order to reduce the risk of mucocele. And the next step is to fill the cavity with fat, as you can see in this drawing, in order to reduce the dead space and to reduce the risk of CSF leak in case of intradural invasion. Also, you can cover the neurovascular structure as a ICA from the nose. And the next step is to close this mucosa of the rostrum using a 5-0 monofilament absample and using this technique, as you can see in this video. So the first note is done inside, and you can after do a continuous suture with 2 or 3 passages through the septum, and the last knot is done outside to facilitate the process. It is a drawing showing this suture of the mucosa of the rostrum, with the first knot inside and the second knot outside near the vestibule to facilitate the suture. Immediately in the postoperatively, you put a silicone sheet on the mucosa in order to improve the healing and to keep it wet. For intradural tumor, you immediately put the patient at 30 or 45 position, as the same concept from the Napoli team, which published the 3F, fat, flash, and flap. Eventually, you put a lumbar drainage for obese patient to reduce the risk of CSF leak. And the silicone sheet was removed after 15 days during endoscopic control, and it is a result of our technique showing a perfect suture of the mucosa of the rostrum here. And the postoperative MRI show a perfect conservation of the anodal structure compared to the preoperative MRI and the piece of fat in place of the tumor. So we decided to analyze our outcome with this technique. We compare the classic noceptal flap technique to our new technique using this mucosa suturing technique. We analyze the rate of external resection, rate of complication, postoperative CSF leak, and in addition, we evaluated the postoperative sinonasal quality of life using this questionnaire, the endoscopic endonasal sinus and skull-based surgery, that takes the advantage to evaluate 3 domains: physical, psychological, and social. Here are our outcome. When you compare the 2 groups, you observe that the rate of CSF leak did not significantly differ between both groups, as well as our rate of CSF leak. However, when you compare the sinusal quality of life between the 2 groups, we observe that patients of the mucosa suturing technique group presented a better outcome compared to patients with the noceptal flap technique, especially for the physical and psychological domains. Finally, for the management of skull-based chordoma, you note a shift toward a multimodal approach in our last period of treatment in order to increase our rate of resection. And as you can see in this table, the rate of gross total resection plus near total resection for skull-based chordoma at the last period is about 91.3% compared to 75% with the endoscopic endosal period. So for this big tumor with intracavernous extension, huge petroclival tumor, big intradural invasion, you use preferentially a stage surgery using the endoscopic approach to resect the intracavernous part, and the open approach using classic lateral transcranial approach to remove this part of this tumor, because we are scared about the risk of CSF leak, rate of infectious complication, and also for this type of tumor with involvement of the different neurovascular structure, you prefer to have a more microscopic access to that allows to separate the tumor from the complex neurovascular structure. So for this type of tumor, you use this combined transpetrosal approach, and we have a good experience with Professor Folish in this approach in our department. But also, Professor Goto published this beautiful technique, the mini combined transpetrosal approach. We shift toward a less aggressive, morbid for the soft tissue, and also for bony structure or neurovascular structure, to this mini combined transpectoral approach that allows to expose only that you need for to resect the tumor. So it is a video of the surgery for this patient. This is classic mini transpectoral approach. The bony flap, you use a mastoid cosmectomy. You drill over the sigmoid sinus, exposing the sigmoid sinus. We drill over the labyrinthine, exposing only the superior and posterior semicircular canal. It's an anterior transpectoral approach here. Here is the opening of the dura along the temporal lobe. Suture the suprapectoral sinus, cut the suprapectoral sinus on the tentorium, and as you can see, we have a good access to this tumor, and you can separate the tumor from the brainstem easily from the neurovascular structure. It's the fourth nerve, fifth nerve, it's here, in order to reduce the morbidity and to have a good control of this structure compared to the endoscopic endonasal approach. Also, for craniovertebral junction, you use this multimodal approach to resect this tumor according to different factors. You preferentially use the endoscopic nasal technique for tumor located above C2 and medial to jugular foramen and hypoglossal canal. And also, when you want to preserve stability, because drilling only the anteromedial part of condyle can preserve stability for the patient. But the main issues are the rate of CSF leak and this nasal morbidity. And for also, you reduce our impact of nasal structure, and we change our technique over the time using this mucosa suturing technique for this lesion. It's a big craniovertebral lesion with a big intradural extension. You use this classic mucosa suturing technique, and as you can see in this drawing, you incise only the mucosa as below to the rostrum and toward the nasopharyngeal muscle in order to not to open the sigmoid sinus and not to remove the mucosa inside in order to reduce the risk of mucocele. It is a quick video of this technique for this big craniovertebral junction chordoma. So we incise the mucosa below the rostrum and towards the nasopharyngeal muscle. Here we access directly to the tumor, and we can remove using this chopstick technique, angle endoscope, angle drill, angle scope, the different part of the tumor, the bony part. We access to the condyle, to the dens. Here it's a hypoglossal canal. And we can resect also the intradural part. Here it's a big piece of tumor. Take it out, and we can access here into the left hypoglossal canal. And it's a view at the end of the surgery showing the different neurovascular structure. And at the end, you put a piece of flap to cover the neurovascular structure, and you suture the mucosa of the nasopharynx in the same technique as you suture the skin for a transcranial approach to have a tight suture, as you can see at the end of the video. It could be challenging, but with the time, it can be done. It is a postoperative MRI showing the piece of fat in place of the tumor, and this in the drawing the concept of the mucosa suturing along the nasopharyngeal for craniovertebral junction and inferior clival tumors. Far lateral approach also is perfectly adapted for tumor above C2, and you use this technique especially for tumor with a big posterior extension, because this big posterior extension creates the working space. Also, you use preferentially this technique when there are bilateral condyle infiltration and there are preoperative instability, because you can resect and fix the patient during the same stage, avoiding a new surgery for the patient. And to resect tumor anteriorly and contralaterally, you use this endoscopic assist technique with angle endoscope, angle instrument to also resect the contralateral part. It is an example of this technique for this big craniovertebral junction chordoma. Using this technique, and we publish this technique endoscopic assist bilateral transcondylar approach several years ago to resect this complex tumor using a posterolateral corridor. It's a quick video of this technique. It is you choose a left side corridor. And the first step to create working space and to access to the tumor is to transpose the vertebral artery. So you open the transverse process of C1 in order to displace medially the vertebral artery and to have a good access to the craniovertebral junction, C0, C1 joint on the tumor. You can see here the tumor is here. Here we drill the occipital bone to have a better access to the tumor, and we can resect the tumor, drill the infiltrated bone, drill the condyle. You can see here. We drill the condyle, identifying the hypoglossal canal. And at what point you are limited by our access, and we decided to use endoscope, the angle endoscope, 30, 45, and 70 degree endoscope, and also angle suction in order to resect the anterior part, the superior part also into the clivus on the contralateral part using this technique. At the end, you put a piece of bone cement to reinforce the stability of the craniovertebral junction, and you put occipital cervical fusion to maintain this stability. And this is a post-operative MRI showing gross total resection, and also you can see the contralateral access with this technique to the contralateral mass of C1. Finally, the anterior approach is also a good approach. It was invented by Professor Bernard Georges from Lariboisière Hospital. You use classically this approach for craniovertebral junction tumor with extension into the cervical spine. Also, you preferentially use this technique if there is only unilateral condyle invasion, because you can keep a certain stability for the patient after the surgery, and you can put a collar doing the proton beam therapy and evaluate at the end of the proton therapy the stability for the patient, because you know that using the titanium plate could hamper the efficiency of proton beam therapy. So we preferentially use this technique when you would like to delay the instrumentation. Also, you can use the endoscopic technique to access to the contralateral side, and also to the superior part of the tumor. Here it's a beautiful dissection showing this lateral access to the craniovertebral junction, but the first step is to transpose the vertebral artery to access to the C0 and C1 joint to resect the tumor. On the contralateral vertebral artery is the limit of this approach. You can use the endoscope to access also to the superior part through different corridor above on as a superior part of the hypoglossal canal. So for conclusion, the new advance of chordoma surgery and the management strategy of chordoma surgery require a shift toward a more personalized treatment with multi-omic prognostic biomarker, and also multimodal approach to offer for the patient the best approach with best quality of life and best external resection. Also, in order to preserve the patient quality of life. Also, in the future, we hope that there are new medical treatment that can help to make a tumor resecable before the surgery, but also to manage this complex tumor with a high rate of recurrence and eventually metastatic problem. Thank you for your attention.
Thank you, Professor Passeri. You your presentation covered the all aspect of the treatment of chordoma. And I know your center, you operate the many cases of the chordoma. So this presentation is very, very informative for us, how to treat the chordoma. So do you have some question from the audience?
So far, none, but we can, of course, include a panelist. Professor Vincent Ng is also an endoscopic skull-based surgeon. Any questions, Prof. Vincent?
Thank you, Professor Passeri, for the very excellent presentation. I'd like to find out, you mentioned about the newer chopstick technique and whether with the minimally invasive endoscopic approach, does it affect the gross total resection? You have mentioned that it's definitely better with the quality of life. So is there any situations where you will still go back and default back to the traditional, slightly larger endoscopic technique? Thank you.
Thank you for your question. Basically, you use for new primary patient without previous surgery or previous irradiation therapy, this mini-invasive technique. But for patients previously irradiated or eventually previously operated, you use the classic technique using the nose-septal flap. But traditionally, you do the chopstick technique for every case now. But it is the smaller is the corridor, the easy to use this technique because the endonadal structure hold also the endoscope and the suction.
May I ask Prof. Passeri about that Chordoma case you showed with a giant intradural component?
Yeah.
The post-op shows the too much of fat inside the
Yeah, but I think
cavity.
yeah.
So how
Yeah,
does it
I
really
am
affect?
agree, but it's a lateral view. It's a lateral view in the sagittal plan. But yes, an issue is to impact a piece of fat, too much piece of fat in the intradural space, and have brainstem compression with this piece of fat. But no.
Right, thank you. Prof. Koto?
Yes, in your presentation, some case of the chordoma rejected by the mini combined transpetrosal approach. In such case, we have to go into the subdural space. Of course, I also operated some case of the chordoma by the mini combined transpetrosal approach, but I always afraid the dissemination to the subdural space. So my question is, do you have some experience after the surgery, even performs a proton beam? Do you have some experience
We have
dissemination to subdural space after subdural approach?
no in our series. I don't think that there is a dissemination case using this transcranial approach. But also for as you can see in my presentation, the majority of these cases receive proton beam therapy. So, but we have no case of dissemination, but it is interesting. And I have seen some case, but for recurrent tumor with dissemination into the intradural part, even also in the lumbar region. But we
Thank
have no
you.
this experience yet. But interesting.
So in case of the conventional chordoma, you not experience dissemination
No,
after the
but
proton
not for primary tumor operated patient. No.
Thank you.
Thank you very much, Prof. Passeri, for this wonderful lecture, and it was really interesting. And congratulations for these wonderful techniques that
Thank
you
you for the
presented.
invitation. Thank you, Professor Goto, also to moderate this session.
Go to Sensei. Any closing remarks?
Thank you. Today, I think all the audience can learn the many knowledge how to treat the chordoma from the presentation from big center in the world. Thank you, Dr. Passeri.
Thank
Thank
you, Professor Goto.
thank you, Sensei. And indeed, it was really interesting and we learned a lot. We'll move on to the second session. I will hand this podium over to our second chair, Prof. Vincent Ang, who will say a short introduction and invite Prof. Xin Shen for his lecture. Prof. Vincent.
Thank you very much for everybody for attending this second session itself. I would like to introduce Professor Xin Chen. He is the Vice Chair and the Chair of the Department of Neurosurgery at Tianjin Medical University General Hospital and is currently a Professor and Doctoral Supervisor at Tianjin Medical University. Today, he'll be sharing with us the surgical anatomy for and the surgery for glossopharyngeal neuralgia. He's the expert in the peripheral nerve surgery, from what I can tell from his CV, and I really look forward to the presentation today. Professor Chen, back to you.
Good morning, good afternoon, or good evening, depending on where you are joining from. It's a great honor to connect with all of you online, and I sincerely appreciate the host for the kind introduction. Over the next 25 minutes or so, I would like to share with you my experience and insights into the surgical treatment of glossopharyngeal neuralgia. In 1910, Dr. Weisenberg from Philadelphia General Hospital performed an autopsy on a patient and discovered a CPA tumor. He suspected it might be compressing or irritating the glossopharyngeal nerve, leading to throat pain. Later, in 1921, Dr. Harris from St. Mary's Hospital in Australia was the first to thoroughly describe the symptoms of glossopharyngeal neuralgia and officially named this condition. And then in 1969, Doctors White and Sweet observed that some patients with glossopharyngeal neuralgia also have symptoms related to vagus nerve. Then they expanded the term to include these cases, naming it vagal glossopharyngeal neuralgia. Interestingly, perhaps by a twist of historical coincidence, the renowned Italian Renaissance painter Sandro Botticelli depict a strikingly symbolic representation of glossopharyngeal neuralgia in his masterpiece Primavera. In the painting, a vine about to bloom along a maiden's cheek and throat, vividly illustrating the pain distribution associated with glossopharyngeal neuralgia. As we know, glossopharyngeal neuralgia is a relatively rare condition with an annual incidence of about 0.2 to 0.7 per 100,000 people. For every 70 cases of trigeminal neuralgia, there is only one case of glossopharyngeal neuralgia. Glossopharyngeal neuralgia also demonstrate a notable gender difference, like the other cranial disorder, with a women to men ratio of about 2 to 1, and rat to life ratio is about 2 to 3. Glossopharyngeal neuralgia is characterized by severe pain, include the area below the angle of the jaw, the external auditory canal, and the tonsillar fossa. The pain can be triggered by actions such as swallowing, chewing, and speaking, yawning. Sorry about that. Approximately 10% of patients also experience bradykinesia, even syncope. According to the diagnostic criteria for glossopharyngeal neuralgia, given or established by the International Headache Society, we should remember two key threes. The first three, there must be at least 3 episodes of a paroxysmal pain occurring within the distribution of glossopharyngeal nerve. And the second 3 is among the 4 key features like pain duration, severity, nature, and triggers. At least the three must meet the diagnostic criteria. And more importantly, it's very important to highlight the red flags, which may indicate conditions other than neurovascular compression. These include the predominant pain is not paroxysmal, but it's like continuous or near continuous. And the characteristic of the pain is not like a stabbing sharp, it's a burning, squeezing, or sensation likened to pins and needles. And also the obvious sensory deficits within the distribution of the ninth and 10th cranial nerve, weak or absent gag reflex, which must be require careful attention. There are two different classifications, one based on etiology and the other on clinical manifestations. According to etiology, classical glossopharyngeal neuralgia, classical GN, refers to cases with evident neurovascular conflicts, which can be identified either on MRI scan or during the surgery. The secondary GN is associated with an underlying condition such as a space-occupying lesion or multiple sclerosis known to cause these symptoms. While the idiopathic GN applies when neither neurovascular compression nor an underlying disease is identified at the cause. According to the clinical manifestations, the GN can be classified into three subtypes: pharyngeal, tympanic, and cardiovascular. Pharyngeal GN refers to the pain located primarily to the pharynx, which is the most common subtypes. The pain typically begins from the throat and radiating to the ear, upward to the ear. And the tympanic GN involves the pain spreads in the opposite direction, starting the ear and radiating to the pharynx. While cardiovascular GN is diagnosed when neuralgia is accompanied with bradycardia or arterial hypotension, potentially leading to syncope and convulsions. Regarding the differential diagnosis of glossopharyngeal neuralgia, it's essential to distinguish it from the following conditions. The first, intracranial space occupying lesions, particularly medullary tumors or tumors originating from the CP angle. Eagle syndrome, when the styloid process exceeds 25 millimeters, or the stylohyoid ligament is calcified, it may comprise the hypoglossal nerve. And also demyelinating disease like multiple sclerosis, inflammatory and autoimmune disease, for example, Sjögren's disease, and posterior fossa and cervical malformation like Chiari malformation, and intraoral and peritonsillar infections and oropharyngeal cancers. The glossopharyngeal neuralgia nerve typically form a single root, originating from the upper part of the retro olivary or post olivary sulcus of the medullary oblongata, and across through the cerebellomedullary cistern to the jugular foramen. At the jugular foramen, a fibrous band divide the foramen into two parts, a rostral and a caudal part. The rostral part, it's where the glossopharyngeal nerve transverse, while the caudal compartment is the vagus nerve and accessory nerve pass through. The cisternal segment of the glossopharyngeal nerve measures about 15 millimeters. For some reason, the transition zone between the transition zone is located exclusively on the ventral side. And this highlights that the importance of adequately exposing the root axis zone at the retro-olivary groove during microvascular decompression surgery. And due to the typical anatomical relationships, the posterior, the pica is the most common vessel compressing the ventral side of the glossopharyngeal nerve, and often located in the retro-olivary sulcus. And in contrast, vessels on the dorsal side are rarely the culprit. Only the vessel compressing the nerve within the post-olivary sulcus should be considered responsible for the neuralgia. In about 5% of the population, there is a direct neural connections between the glossopharyngeal nerve and the vagus nerve. Research conducted by Dr. Kruger's group revealed that the vagus nerve typically consists of an average of 6 rootlets. And his group have done a very interesting study. Intraoperative neurophysiological monitoring showed that in about 50%, about half of patients, the rostral half, 2 to 3 rootlets of the vagus nerve contains purely sensory nerve. And in the remaining patients, all the rootlets of the vagus nerve contain motor fibers. This provides two important insights. Number one, compression of the vagus nerve may also contribute to glossopharyngeal neuralgia. And the second, under no circumstances should any rootlets of vagus nerve be sectioned indiscriminately. There is a 50% half chance of causing significant neurological dysfunction. Here, I would like to emphasize the complex sensory innervation of the external ear as it relates to glossopharyngeal neuralgia. The external ear includes the auricle and the external auditory canal. The upper part of the auricle is innervated by the mandibular branch of the trigeminal nerve, and the lower part of the auricle is innervated by the greater auricular nerve originating from C2 to C3. And the skin of the concha and external canal is innervated by a combination of the facial nerve, glossopharyngeal nerve, and the vagus nerve. So this understanding helps us better explain the ear's irritating pain pattern in the glossopharyngeal neuralgia. Now let's correlate this with the anatomy and review the imaging studies. Here is the upper medullary oblongata as viewed from below, with a microscopic slice showing the glossopharyngeal nerve nuclei with an axial T2 weighted MRI at the same level. Below is the corresponding axial T2 weighted MRI, where we can identify the key structures like pyramids, olive, retro-olivary groove, and the inferior cerebellar peduncle. And on this CT scan, we can easily recognize the flocculus and the calcified choroid plexus. Here, I would like to mention, although advances in imaging allow us to clearly identify blood vessel with a diameter greater than 1 millimeter, the absence of visible vessel on MRI does not necessarily mean they're not present. Here are some representative imaging results from our recent cases, they clearly demonstrate the vascular compression on the ventral side of the glossopharyngeal nerve at the retro-olivary groove. I would like to say more than 95% of patients, the compression is located at the ventral side of the glossopharyngeal nerve. The treatment option for glossopharyngeal nerve, similar to other cranial nerve disorders, include both medical cell therapy and surgical interventions. And medical therapy primarily involves monotherapy with oral anti-epilepsy medications. The first line medications is carbamazepine and oxcarbazepine, and additional AED can be considered like lamotrigine and gabapentin. Surgical treatment can be divided into destructive and non-destructive procedures, and non-destructive treatment is what we are talking about today. Is primarily the microvascular decompression, and the destructive treatment includes sectioning of the glossopharyngeal nerve and upper rootlets of the vagus nerve, and the radiofrequency thermal coagulation and the stereotactic radiosurgery. And currently, evidence-based medicine strongly supports microvascular decompression without sectioning as the best treatment option for this condition. As a surgeons, our primary concern is determining which type of glossopharyngeal neuralgia patients achieve the best outcome with microvascular decompression. Early studies give us very clear evidence. It's like for patients with a single clinical symptoms, such as isolated throat pain, the success rate of pure microvascular decompression exceeds 95%. However, if the single symptom is pain limited to the external auditory canal, the outcome is less predictable, with a success rate of only 30%. The preoperative evaluation for glossopharyngeal neuralgia is something we are all very familiar with. It typically involves routine assessments, includes ECG, laboratory tests, and ultrasound examinations. Here, I would like to particularly emphasize the importance of imaging studies in the evaluation process. Several imaging studies are routinely performed in my department as part of the preoperative evaluation. This includes a temporal CT, T1, and the contrast-enhanced MRI, T2 weighted and the volumetric heavily T2 MRI, and the 3D TOF MRI. On the temporal bone CT, we use it to identify the sigmoid sinus groove, the extent of mastoid antrum, and the mastoid emissary vein, which are essential for tailoring a safety craniectomy. On T1 weighted MRI, we could evaluate the presence of Chiari malformation. And also on the contrast enhanced MRI, we would like to see if there is any enhancement of cranial nerves. And with the help of the T2 weighted MRI, we can identify the size of the cerebellum medullary cistern and also the CSF space overlying the cerebellum. And also very important with the 3D heavily T2 MRI and the 3D TOF MRI, we could precisely identify the potential neurovascular conflicts, the corporate vessels, the inferior petrosal vein, and the morphology of the glossopharyngeal nerve. But we can only use this combination to identify the corporate vessel larger than 1 millimeters. Topical anesthesia of the oral pharynx is crucial, not only for facilitating diagnosis, but also for ensuring safe intubation during general anesthesia. The tetracaine, we do the tetracaine spring test to see if the pain is immediately relieved. If so, it confirms that the diagnosis of glossopharyngeal neuralgia. And during general anesthesia, administering atropine prophylactically and anesthetize the ultrapharynx, particularly on the side of the pain, with the topically applied lidocaine before intubation is super important. And additionally, correcting the fluid deficits with the intravenous fluids before surgery is also necessary. We do the infra and lateral follicular microvascular approach for glossopharyngeal neuralgia microvascular decompression. In terms of the patient positioning, we prefer the lateral decubitus position with the shoulder drooping, as shown in this picture. This positioning allows us for better head tilt toward the floor, increase the operating angle and space, and it facilitates the venous return from the jugular vein. We also use the inverse Trendelenburg position. Head of the bed is elevated at 20 degrees, and also the head rotated until to the ground at 10 degree, and the head flex that the chin is 2-finger width from the cistern, and the plane of the shoulder is tilted about 60 degree horizontally, and we try our best to keep the peak airway pressure less than 20 centimeters of water. And sometimes we forgot about it, but now we pay every nuance of this technique. It's like the Foley catheter should never be obstructed. And also, we would like to do a retro auricular linear incision within the hairline, about 4 to 5 centimeters, which is tailored to the patient's body type. We prefer about 2 to 5 centimeter craniectomy instead of a craniotomy. Let me now share a few cases with you. This is a 62-year-old male presented with a 2-year history of a right-sided burning, stabbing pain in the mandibular area and the back of throat. And pain is exacerbated by speaking, swallowing, and coughing. And the previous treatment with carbamazepine stopped due to rash, and a failed treatment with other anti-epilepsy medications. These patients experience intense pain, with each episode lasting near a few seconds and occurring every few minutes. The pain was often followed by coughing. We performed the tetracaine spring test, after which the pain completely disappeared and could no longer be triggered. His neurological examination was intact, and the gag reflex was very sensitive. And the MRI study was remarkable, except for the pica loop at the retroolivary groove compressing the glossopharyngeal nerve. Throughout the entire microvascular decompression procedure, many small details are important. However, I would like to particularly emphasize a key point we previously reviewed and shared is almost all corporate vessels are located at the retroolivary groove on the ventral side of the glossopharyngeal nerve. This means that during surgery, it's essential and other importance to fully expose the retroolivary groove and clearly visualize the regions of the cranial nerve ninth and the 10th from the medulla. And now let's take a look at the surgical video. So we fully released the arachnoid membrane and carefully separate the caudal cranial nerve separate the caudal cranial nerve from the flocculus and the choroid plexus. And starting from the caudal end of the vagus nerve, we expose the retroolivary sulcus. Like we discussed before, during this kind of procedure, it's super important to visualize the post-olivary sulcus, just as essential to identify the attachment segment when we do the MVD for hemifacial spasm. We successfully expose the retroolivary sulcus and identify the pica loop comprising the nerve in the most classical location. We then carefully mobilize both ends of the corporate vessel and place a Teflon implant to separate it from the nerve. And finally, we confirm the corporate vessel was fully mobilized and the pain was completely gone right after the surgery. The second case is a 56-year-old male presented with a 3-year history of left-sided stabbing, pain in the ear and the back of throat, and an Adam apple. And pain that was exacerbated by speaking, swallow, and coughing, and it was so severe that could not be controlled by even a 2,500 milligrams dose of carbamazepine. So the procedure, it's pretty similar. I usually dissect the arachnoid membrane and carefully separate the caudal cranial nerve from the flocculus and the choroid plexus. Starting at the caudal end of the vagus nerve, and then identify the potential culprit vessels at the ROG and ventral to the vagus and the glossopharyngeal nerve. Afraid the culprit vessel caudally and place a Teflon felt to push the vessel ventrally. And next, I dissect from the rostral end near the glossopharyngeal nerve and place another Teflon felt to fully mobilize the vessel. The pain completely gone right after the surgery. So this is to show we need to fully decompress not only the hypoglossopharyngeal nerve but also the vagus nerve. And the third case is a 66-year-old male, a female, presented with a 6-month history of right-sided stabbing pain in the deep throat, and the pain that was exacerbated by swallowing and coughing, and the pain was not well controlled with carbamazepine. After fully dissecting and releasing the caudal nerve, a large tortuous pica was observed compressing the glossopharyngeal nerve from the ventral side, causing significant nerve compression, distortion, and deformation. And once the culprit artery was thoroughly mobilized, a gelatin sponge was first placed and created a space between the vessel and the and the medulla oblongata, and then a Teflon implant was then positioned for further decompression, and the patient experienced immediately pain relief after surgery. And the fourth case is a 33-year-old male presented with a 5-year history of right-sided shooting pain in the ear and back of the throat. And the pain was initially controlled, but eventually the medication became ineffective, leading to an inability to drink water or eat. Due to the time constraint, I will not be able to show the entire video. Instead, I'd like to use this case to highlight an important point. Although no clear culprit artery was identified on preoperative MRI, we find during the surgery a artery less than 1 millimeters was specially wrapped around the hypoglossal the glossopharyngeal nerve, and also we could clearly see the demyelination area on the surface of the glossopharyngeal nerve. And after the Foley decompression, and the patient are very happy about the immediate relief of the pain. So in conclusion, microvascular decompression is a safe, effective form of therapy of glossopharyngeal neuralgia. And the microvascular decompression is most beneficial for patients with a typical glossopharyngeal neuralgia when symptoms are restricted to the deep throat only. Microvascular decompression for both 9th and 10th without any sectioning cure more than 90% of glossopharyngeal neuralgia. And topically anesthetizing the oral pharynx is the most important trick to diagnosis this condition. Thank you very much for your attention.
Thank you very much, Professor Zhenxing. It's really impressive to see your series, especially for such a rare condition. And also, I truly appreciate, I didn't know that the relationship with the Sandra Botticelli painting, because it really takes me back to Florence at that time. My question to you, Prof, is you mentioned if you have a patient who have classical GN, and also and pass the TST test, but yet if you do not see the neurovascular conflict on your T2 cis sequence, would you offer a surgical exploration?
Thank you very, very much for your excellent question. Yes, I do. So I think the surgical indication is really depends on the classical symptoms instead of the imaging studies. So as I mentioned during my presentation, at least in my hospital, we could only identify the artery larger than 1 millimeters. So one of the case I clearly show us is like the blood vessel is very small. The size of the diameter is less than 1 millimeters, and I don't think we can confidently or clearly see that small vessel on the routine T2 heavily imaging study. So if the patient has a very classical symptoms, even without see any neurovascular conflict, I would also confident to do the microvascular decompression.
Maybe the next question, just a small question. Besides the pica artery, if you see veins or very large vessels that you, even with the interposition of the Teflon, do you ever use, like, for example, slings? And what do you do with the veins? Do you just coagulate with them?
Yeah, so that's another very great question. So it's, as we know, it's very, very rare we never encounter vein might be the culprit vessel for glossopharyngeal neuralgia. It's not like a trigeminal neuralgia. So for this kind of neuralgia, I never like say sacrifice or do any ablative or microrhizotomy for this nerve. It's not like trigeminal neuralgia. Trigeminal neuralgia is another. I think it's way more complex than a glossopharyngeal neuralgia. So that's why I really love to do the surgery for this kind of group of patients, not for trigeminal neuralgia patients. So I think the transition zone is very clearly located in the ventral part. So it's very, it's like every patient had the same location, the same area. You just decompress that area, and then boom, you got a very excellent result.
Thank you. I'm not sure whether there's any questions in the floor itself.
There are none, but still we can invite comments from Goto Sensei and Bhakti Balpasiri as well as Sensei. Any comments?
Thank you, nice lecture. I have the one question. When we treat the glossopharyngeal neuralgia, transposition of the vessel very difficult. So we have to insert some material. So do you have some experience after insertion the material, it
Mhm.
causes a granulation and uh, show the need the reoperation or not? Do you have some experience?
Mhm. Yeah, thank you very much. And also, I'm really sorry, forgot to answer the same question from Dr. Vincent. It's like the
Mm,
transplantation technique. So I think for here, it's very interesting. I don't know what the reason is, but it looks like here, the interposition cannot cause any trouble about the like say the recurrence. It's not like
mm,
the trigeminal neuralgia. So fear
mm,
I don't worry about like say if I interposition, even there is a small branch, there is very difficult to fully fray the corporate vessel. I just insert several pieces of the Teflon felt. But so far, from my humble experience, I never experienced any relapse
mm,
about this kind of technique. And I do agree with you for this kind of area, it's really hard to do the transposition, especially this small
mm,
artery. And we in my hospital we only have the Teflon. We don't have other interposition materials.
mm. Okay, thank you. Mm.
Thank you very much. Yes, Bhakti Balpasiri, any questions from you?
Yes, thank you for this complete presentation. I have just a question about sometimes if do you use endoscopic assistant for your surgical technique to see see if there is a doubt about the conflict between nerve and the vessels?
Yes, I do. Yeah, I totally agree with you. The endoscope assistant procedure is excellent. It can give you like say better angle to see uh, the the corporate vessels. But sometimes, if I do use the endoscope, I'm not sure what's your experience. I need to do a larger craniectomy, and also the incision size is a bit larger. So because nowadays it's very competitive, we try our best to make our patients happy. So we want the incision is a smaller and smaller. So that's one of the reasons sometimes I don't always use the endoscope. Yeah.
Okay,
Thank you very
thank
much.
you.
One question to Prof. Sinchan is how many cases have you encountered where you had to do a microvascular destructive procedure like a interfascicular rhizolysis?
I'm sorry. Could you repeat your question?
In any, have you ever encountered any cases of glossopharyngeal neuralgia where you had to do a second procedure in the form of an interfascicular rhizolysis, which is the combing surgery? You divide the root nerve into several rootlets. Have you had any
Okay, so you mean to do the combing on the neural?
combing? Yeah, yeah,
Okay. So I never do any a destructive procedure for glossopharyngeal neuralgia, but for trigeminal neuralgia, sometimes I did.
yeah.
Yeah.
When in 2018, Professor Kato presented a case in World Neurosurgery. We published it, and it was
Mhm.
a case where recurrent glossopharyngeal neuralgia and interfascicular rhizolysis was done. And another question: what type of neuromonitoring do you use? Do you use a endotracheal tube with monitoring in glossopharyngeal neuralgia?
Uh, so unfortunately, I never do any neurophysiological monitoring for this kind of procedure because it's very low. And also it's like you elevate the cerebellum. It's if you do the microsurgery, it's very gently. It's very rare to harm the hearing, to harm any kind of things, and also because sometimes the facility is very limited. Sometimes we have several cases a day, so from the very beginning, I use everything, but right now I seldom use the neurophysiological monitoring because I never did sectioning. So just microvascular decompression.
Thank you very much. So we come to the end of this session. We can hear the concluding remarks from Prof. Vincent.
Thank you, Robert, Professor Chen, for your excellent sharing. We really have learned a lot on this condition itself, and especially with the historical aspects and also showing us all the TST. We benefited from the presentation, and thank you for your very excellent work. Thank you.
Thank you very much.
Thank you very much. So that with that, we'll come to the end of the webinar. I'll close this officially on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both speakers of today, Prof. Tibal Paseri and Professor Sin Shen, as well as the chairs, Prof. Takio Goto and Professor Vincent NG, for the time and support for the ACNS webinars. We'd like to mention that this is being broadcasted on WeChat, YouTube, and Zoom. And thanks to Professor Shubin, today we have around 540 people who are live now on all the different channels. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.